Good morning everyone. Welcome to this week's staff brief. I'm Paul Robinson. I'm the Chief Executive here at Sherwood, and with me today I've got a cast of guests. So I've got Craig Short and Barbara Yorchik and Anna Hume. Craig and Barbara are part of our clinical audit team, and Anna's part of the pharmacy team, and they're going to talk about clinical audit week. And Anna's going to share the work she's been doing on antimicrobial stewardship on ward 34, I think. But Anna will, she's nodding, I've got that right. Thank you, Anna. And first up will be Sally Palmer, our nurse consultant in infection prevention and control, and Adam Grundy, head of occupational health, who'll be talking about the changes that we've implemented this week on wearing face masks across the trust. I've got one or two updates just to cover before I hand over to Sally and to Adam first up. And the first one is response to a question that we received last week on the electric charging points here at Kingsmill Hospital. I'm pleased to say that after much badgering, the engineer will be arriving tomorrow to fix the electric point and to repair it. So hopefully all that'll be up and running tomorrow evening. Next up, I want to recognise that today is National Healthcare Estates and Facilities Day. So this is the inaugural National Healthcare Facilities Day, and it recognises the hugely important role of our estates and facilities team, and time to recognise and to praise the teams for the value that those professionals bring to Sherwood Forest and indeed to the NHS. So thank you for everyone who contributes from the estates and facilities team. And then lastly, just wanted to recognise that last Friday was the start of the two new appointments to our executive team. So Richard Mills took up the role of Chief Financial Officer, and Rob Simcox took up the role of our Director of People last Friday. So I know that most people will be really familiar with Richard and Rob. Richard's been a Deputy Chief Financial Officer here for 3 years, and Rob's been here longer. He's been here 6 years as Deputy Director of People. So I'm really pleased that Rob and Richard are stepping up into those substantive executive roles last week. So I'll move on now. So just remember that if you've got any questions, please drop them in the chat as we go along. We'll pause at a couple of suitable points to do so. And firstly, I'll turn to Sally and to Adam, who are going to update us on the changes that we've implemented this week on the compulsory requirement to wear face masks. So over to you, Sally and Adam. Thank you.
Thank you, Paul. Morning, everyone. So yes, as Paul's saying, our guidelines have changed. We did receive some new national guidance with regards to the compulsory wearing of masks across the organisation. And so we have reviewed that and implemented the changes as of yesterday within the organisation. So we've reduced masks in non-clinical areas, and teams don't have to wear them. And again, in clinical areas, we've reduced the use of masks to transmission-based precautions unless you're in a high-risk area where we've got, which is classed as a high-risk area such as ITU, NICU, RSU, or where we've got immunocompromised patients, or where we've got a significant amount of COVID patients would be classed as those areas. So we will be continually reviewing our high-risk areas to see if we need to add people to that list or if we need to remove people from that. So we will be doing that on a regular basis, but we're following what's happening in other organisations as well. So we are looking at what's going on regionally and how everyone else is implementing the new guidance, and we're all taking a very similar approach with it and our interpretation of the guidance. I do know that, you know, if people still want to wear a mask, it is preference as well. You don't have to stop using them. You can wear them if you want to. That's not a problem at all. And if people have got respiratory symptoms coming in, we would still ask them either, if they don't need to attend, not to attend the site, or to wear a mask when they do come. So lots of changes happening, and we know that we are seeing increasing numbers of guidance changes. And so we're trying to work through those, and like I say, it will be a process. We'll be moving to social distancing next. So we're looking at stepping down social distancing in the next couple of weeks. We're aimed for that on the 27th of June. So we're taking a stepped approach, and at that time we'll look at fully implementing our old visitor policies again as well. So we'll review this process, make sure we're not seeing any increased cases and no problems from removing masks, and then we'll look at stepping down some of our other precautions that are in place. And I'll let Adam do his staff bit for you.
Thanks, Sally. Yeah, that's brilliant. I think ultimately for the majority of colleagues, this will be seen as a positive step forward in how we start to move COVID into our sort of history and into our memories. But obviously acknowledging that for a few staff, this is also going to cause a bit of anxiety and a bit of uncertainty as we move forward. So as Sally says, if people want to continue to wear masks, then do so. That's absolutely fine, and we need to be supportive of colleagues who make that decision. From a risk point of view, this has been a measured approach and really considered, and we don't feel that not wearing a mask increases the risk significantly for any of our colleagues. So to give a lot of reassurance that the decision has been considered carefully and we don't feel the risk is going to increase, but at the same time, any colleagues who do feel that their perceived risk, has increased, then discuss with your line manager, have that chat, go through the risk assessment again, and if you need any advice, after speaking to your line manager, contact occupational health, and we can hopefully point you in the right direction as well. But I think we mentioned as well the social distancing. We've still got a raft of mitigations in place that we're still doing. We're still doing social distancing for the time being. We're still going to be encouraging people to open their windows, to use ventilation, good hand hygiene, good environmental surface cleaning. So there's still things in place that we're doing to mitigate that risk. So as we move forward, we will only gradually start to drop off these things. So hopefully we won't see an increase in the risk. And if we do start to see it's having a negative impact, then of course we will review it. And if we need to roll back changes, then we can do.
Thank you, Adam and Sally. We've got a couple of questions, and I guess one of them I was going to pick up myself, so I'll ask that one first. And that's about I think you covered it a little bit, Adam, on the risk assessments for staff. But I've got a question about what if staff are immunocompromised, and how is that working with working in among staff who won't now be wearing masks. And I think in your update, Adam, you suggested that conversations should take place with line managers, and then you referred to a risk assessment. So what and a conversation with yourself or colleagues in occupational health. Just talk us through that risk assessment and how the individual who's asked the question can feel that that's been taken forward.
Yeah, that's right. So the risk assessment process that we have at the moment is still the same as it was previously. So the existing individual staff risk assessment remains as it is. So I would encourage anyone who is concerned to review that risk assessment with their line manager in light of the changes. But obviously, as I mentioned previously, we don't feel that removing the mask from the situation has changed the risk anyway. There is a general feeling of a move towards, rather than having a specific COVID risk assessment, to try to bring COVID into our general risk assessments that we would have been doing anyway, such as for TB or chickenpox for staff on the ward. I think it's easy from occupational health for us to say about doing risk assessments, and we sort of sometimes can slip into assuming that managers are already doing those risk assessments for infectious diseases. But I think COVID has just highlighted it a little bit more and brought it into everyone's mindset. So a move hopefully away from an individual risk assessment for COVID and just bringing it into the general risk assessments that we do. But in this scenario at the moment, if managers have that conversation, just review that risk assessment, and if they are unsure of anything, then to contact occupational health.
Thanks, Adam. And then a couple of questions. I think for you, Sally. So I think we've covered that the current social distancing rules remain in place. So could you remind us what they are and how long they'll remain in place for? And then there's a separate question about the need to continue to wear aprons and gloves.
Okay, yes. So from a point of view of social distancing, so in all of our areas, non-clinical areas, our outpatient areas, we're down to 1 metre social distancing. On the wards, we do still remain at 2 metres, but the reason we're at that is because we were always at 2 metres and more on the wards prior to COVID anyway. So, and we will be keeping those distances there. So we'll be asking for the 1 metre distance to be maintained until at least the 27th of June, when we've been able to review the changes with the mask to see if that's had any impact and increased any risks there. And then we'll look at dropping that down. But yes, so at the moment it's 1 metre for social distancing. And from a point of view of gloves and aprons, so they are to be worn when we would have done prior to COVID. So if we're going to see a patient and there's potential of coming into contact with blood and body fluids, then we should be wearing gloves and aprons. We don't need to be wearing them all the time. So you know, we don't need to be wearing them for general contact. It's when we're having doing personal care or providing care where we may be coming into contact with blood and body fluids. Any other times when we're doing medications and things like that, where we would have usually worn them prior to COVID, but people don't need to be wearing them all the time anymore.
Thanks, Sally. That's really clear. A question about buffets, and we've had many a conversation about these over the last couple of years. So is it how do the rules apply now? Is it now possible to have buffets and food sharing, etc.?
I would recommend that we still remain sensible with it, and because when you've got I mean, as Adam was saying, there's still other infections that we see. We've still got norovirus circulating in the community and within the organisation recently, so it's still being mindful of everything else and the reasons why we reduce the use of shared food. So where we can, you know, just being sensible, making sure we've got, if we are having shared food, we've got alcohol gel available, people are doing the hand hygiene, because it's very often you'll see people just sort of nipping in and picking things up and out of the shared bowl of crisps and things, and they've not potentially done that hand hygiene. So it's just because there are still lots of other things other than COVID that we're at risk of. So it's just being taking a sensible approach to it now and looking at the environment that we're in when we're doing that.
Thank you, Sally. And there's a last question. I'll probably start, and you can add if you think you need to. So the question is a more general question about the rate of infections nationally is increasing. So that the question is, shouldn't we be increasing the protection, not reducing it? And I guess, you know, I'll kick off an answer to that. We've been really clear here at Sherwood that we followed the national guidance throughout all of the pandemic. So we stepped up those precautions when we were required to, and we were guided to by our national public health and regulators and the Department of Health, and we are stepping it down in line with the national guidance. Clearly, there are assessments that will and scrutiny that will be taken to ensure that what we're doing is safe, and if there are any outbreaks or any increase of infections amongst our staff and people on site here at Sherwood, then we'll be taking a different approach and stepping those precautions back up as we think they are necessary. Sally, have you got anything to add to that?
I think you're right. I agree with what you've said there, and I think just to note that we do have trigger points in place. So we have got certain things in place that we know if we hit that within the organisation, we'll start to step things back up. So we already know where we're going to be and where we need to be to step things back up. So we've already started planning for that just in case.
Okay, thank you. So I think we can move on to Craig, to Barbara and to Anna, who are going to talk to us about the super work that clinical audit does in terms of improving patient care, but also celebrating Clinical Audit Awareness Week with everyone here at the Trust. So Barbara, Craig, over to you.
Morning, everybody. Thank you for inviting us to the staff brief. And yes, we are celebrating. There are things to celebrate. We are mid the Clinical Audit Week, It happens every year. It was usually in November, but this year it's in June. There's few events that was we still got to celebrate this week. So today we've got the staff brief. Every day there's an NQI Icon Lunch and Learn session. They start at 12:30. You can see the links on the intranet. We have got dedicated intranet Clinical Awareness Week site, so you've got all the links there or in the bulletin as well. The NQI Lunch and Learn sessions are fantastic sessions. So the national guests, and they announced the Audit Hero Awards as well. Still to come on Thursday and Friday, me and Craig will be interviewing experts in the trust. So please join the MS Team sessions, and there will be a quiz as well with a few questions to answer. And many more sessions. So I will refer you to the intranet or the links on there. Can I have the next slide, please, Craig? Just to highlight to you that audit, it doesn't stand on its own. It is part of something bigger. It's part of the continuous improvement and the improvement foundations. So as a trust, we have got the quality strategy 2022-25, and as you can tell, the foundation, one of them is clinical audit as well. So please bear that in mind. Clinical audit is not on its own. It is part of something bigger, and we want to spread the word of continuous improvement, because this is what it is. It's an improvement tool by definition. Can we move to the next slide, please, Craig? And apart from the quality strategy, we also have got the people, culture and improvement strategy, and we want to be on the same page with everything. We want to be on the same page with the definitions and the vocabulary that we're using. Improvement across the board, continuous improvement. And as you can tell, we've put in a framework of six steps of the journey, the continuous improvement journey, and one of them is clinical effectiveness and clinical audit. So let's remember that clinical audit is not just about data collection, it is about improvement. That's where we want to shift that thinking from data collection to improvement. And there's steps around being on the same page, being showing the improvement methodology, being one definition, the clinical audit element, the innovation hub, so a single digital platform for colleagues to launch the IDs, the citizens' engagement and improvement. So the patients, the carers, families, that's very important, because mostly they are affected by any improvement work that we do. Knowing how we're doing, so we've got a maturity matrix as well in QI, which tells us where the gaps are. And I do mention improvement as well, QI and improvement, because this is part of everything as well. Can I have the next slide, please? And I will hand over to Craig.
Thanks, Barb. I'm going to warn you, my internet keeps cutting out, so I apologise if I keep freezing. So this just kind of picks up on a point that Barb just made, and this is one of our favourite slides that we use in a lot of the training that we deliver. So this is a Palestinian proverb, and it is, you can't fatten a cow by weighing it. And if we think about it, we collect lots of data when we do audit in the trust, as well as other things, patient feedback, staff surveys, etc. It's all very well capturing that data, but what we really need to focus on is what we're actually going to do with it, and how do we use, or what tools can we use to actually then use that data to inform improvements that we might want to make, to check that improvements that we've made have actually led to that improvement that we seek to achieve. So we like that slide, and we thought it'd be quite a fun one to include this morning. So we also wanted to just pick up, we don't want this to be training. You know, we feel like the message of us telling you all about how great audit is, what we actually think is it's better if we have people who are living and breathing it every day, doing it on wards, etc., is a kind of way of motivating people to take part. So this slide we share as well as part of our training draws on that link. So the right hand side here is called the model for improvement. And the way that audit fits in, so we use audit to identify where a problem might be. So we might be measuring against some nice guidance, for example, it might be a local policy or SOP or pathway. We use audit to kind of look where the gaps in that care are occurring. What we then do, or should do, is identify one of those gaps that we want to try and fill, I guess, by making an improvement. And this is where QI in the model for improvement comes in. So we would look to, rather than just deciding that I think a poster will fix it, or maybe changing documentation will fix it, what we're trying to encourage people to do is actually do a little bit of discovery as to what the root cause of that problem might be. Do it in teams rather than it being individuals. So we get a lot of audits that are carried out by one person working on their own, trying to influence, trying to make change. It's really important that that's done as a team sport rather than an individual sport. Do that QI project potentially, and then we use re-audit, so that cycle gets completed where we actually look to see whether that change using those QI tools that happened actually leads to that improvement. And then that audit also, if we were to collect data over time, we're also able to assure ourselves that that change is actually sustained. So yes, we've changed the way that we've changed practice, and we're actually continuing to work that way. We haven't reverted to type. We haven't gone back to the way things were being done previously. So where can you find out more? So we have an improvement hub. You might not realise this, but part of the library was very generously given over to us by the library team. That there's an area, and every Tuesday and Thursday afternoon, a member of our team bases themselves in the library. So it's a Tuesday and a Thursday between 1 and 4. Also Newark every last Wednesday of the month, and we're also trying to just negotiate when we're going to be cited at MC8. But we invite anybody who might be doing an audit, might be doing an improvement project. It's almost like a little clinic. You can come and visit us, just drop in. It's a drop in. There's no need to formally book anything. And if you need some advice, then please come and see us, and we will do our best to help you, to inform you, to give you some guidance about as to how you can progress. Also, if you need to understand how to overcome a particular barrier that you might be experiencing in your project, then again, we're there and we're more than happy to have that discussion with you and give you some coaching. More formally, we offer clinical audit training. That's an e-learning on the Assured Academy, and that can be accessed using your Trust login for that. We also offer AMAT training. So AMAT is our Trust audit system that we use, and also QI system. There's also, if you want to do improvement training, so we do a one-day, it's called QSA Fundamentals. It's a one-day session, but usually between 9:30 and 4:30, and where we'll take you on a bit of a whistle-stop tour of improvement, and you can hopefully pick up some tools. And if that's something that you're interested in and you feel like you want to look into that in more detail, then we also offer a 5-day training course. Now that's delivered across the ICS, so that's where I am today. That's why I'm not on site. I'm out in the ICS community delivering a session for the day on it's about sustainability and improvement today, but we've got colleagues from the CCG, colleagues from NUH, colleagues from NOTS Healthcare, so the wider ICS, and that actually gives you a bit more of an appreciation of some of the challenges. You can have conversations with colleagues from other trusts who may have a similar problem, might work in a similar area as you do at SFH, and it's a really way of having that rich conversation. The environment's fantastic, and you tend to get a lot out of it. So we'd encourage you, if you do the 1-day QI training, to then potentially do the 5-day, because it's all about building capacity and capability in the trust that then leads us to be able to, follow that journey of continuous improvement, which is what we're trying to achieve, to make it changes everybody's business really. We all have our day jobs, but we should also look at improvement as one of our day jobs as well. If we see something that we don't think is quite right, everyone has permission to try and make that better. And that's what we're here to do, to help support people on that journey if they need that support. Barb, I'm going to pass this back to you to do this bit.
Thank you, Craig. So very quickly, hot off the press, AMAT will have a QI module coming in July. So those of you who are interested in or have been using AMAT so far, there will be a new little circle, pink one, with QI, where you will be able to register your project. it will take you through 6 steps. It will have pre-downloaded tools for each of the steps. So your fishbone diagram, driver diagram, sustainability tool, and it's going to be all in one place. So very exciting. We can't wait. Just going to introduce us to the team. If you don't know the team, so that's us. We've got a Twitter account and the general email address. So please feel free to contact us. I will hand over to Anna now because she will tell us about an exciting project, a lift example of a fantastic project that they did on Ward 34 to start with for antimicrobial stewardship. Very important subject, and yeah, I'll hand over to Anna now.
Thank you very much. I'll just try and share my presentation. Okay. Right, thank you for having me speak today. My name's Anna. I'm one of the antimicrobial pharmacists here at Kingsmill, and I'm here to talk to you, as Barb said, about a quality improvement project on Ward 34, which started in December 21, and with the aim of improving antimicrobial stewardship at the Trust. So first of all, a bit of context. So why bother with antimicrobial stewardship? So a World Health Organization report from 2019 stated that each year antimicrobial resistant infections are estimated to cause 700,000 deaths globally, and that figure is predicted to rise to 10 million by 2050 if no action is taken. And the World Health Organization cites antimicrobial stewardship as one of the ways in which the development of resistance can be slowed down. So that's a bit of context as to why we're doing this. It's for patient safety and to prevent antimicrobial resistance. So what was the driver for this project? You may have heard of the antimicrobial prescribing audit. This is a quarterly audit, so every 3 months, done on every ward in the hospital with a couple of exceptions. It measures compliance against the Trust antimicrobial prescribing policy and the relevant NICE guidelines. And from the results of this audit, we noticed that some wards required improvement with their antimicrobial stewardship. Ward 34 was one such ward, and fortunately was a really supportive and motivated environment with very clear leadership from consultant endocrinologist Dr. Hannah Engwell. So, and they were very welcoming of us doing the audit on that for that reason. We knew that we wanted to help Ward 34 improve their antimicrobial stewardship, but we weren't sure where to start, how to structure the project, or how we would even know if our interventions had made any difference. So we contacted the quality improvement team, who were instrumental in getting the project off the ground and moving it forward in the right direction. Just quickly before I go through the PDSA cycle, some of the ways that they helped were helping us to select appropriate measures, so we knew whether things had improved or not. They set up routine meetings with us to support us throughout the project. They helped us identify relevant stakeholders and offered us advice as to how to involve them and when at every stage. And showed us powerful tools to help interpret and map our data. For example, in a later slide, I'll show you a statistical process chart, which really opened our eyes as to which interventions had sort of made a significant difference. And they helped us analyse and interpret the data as well. So this is stolen from the QI team, this slide, and it just takes you through how to structure a quality improvement project and how we went about it. So we asked 3 questions. So first of all, what are we trying to accomplish? This is the aim. So I've already said, so we wanted to improve the standards of antimicrobial prescribing, and we've got a very clear definition of them because we've got the Trust antimicrobial prescribing policy, so we use that. On Ward 34, so we've got a specific area, and we set a bit of an arbitrary target. If I get time, I'll go into that a bit later, but The baseline compliance on Ward 34 with the antimicrobial prescribing policy was 59%. It was below average. And then we ask, how will we know that our change is an improvement? So this is our measures. We used the quarterly antimicrobial audit. We just used the same audit to measure, but we just did it a lot more frequently. So we audited weekly instead of quarterly, obviously. We did a minimum of 10 prescriptions each week. We did miss some weeks, but I'll go into that later. Which made it easy. You don't have to reinvent the wheel. If there's already an audit that asks the questions that you need asking, you can use it. And then the third question, what changes can we make that will result in the improvement we seek? So our changes. So these are some of the interventions that we made. And we came to these weren't just plucked out of the air. We used QI tools to actually map some of the specific issues that we were seeing on Ward 34 and actually come up with interventions that we thought might actually alter that. Yeah, and then you just re-audit. So you make a change, then you re-audit. Re-audit a couple of times if you can, and then make another change and see if that makes any difference. And so our QI project was born. I've already gone through most of this, but what I will do now is just go on to some of the interventions quickly. So the first intervention that we made was a podcast. This was aimed at nurses, and we in the antimicrobial team, we think nurses are a really untapped resource in antimicrobial stewardship. Who's seeing the chart multiple times a day? The nurses. Who knows that the patients can be switched to oral? You know, they've got an oral route. They can take things orally. The nurses know that. They're in a really good place to actually flag to doctors when antibiotics are due, like a 72-hour review. So we aimed 2 of our interventions specifically at nurses. That's the podcast. This podcast, what I do need to say, it was quite specific to Ward 34. We could make it more sort of general and make it more widely available, but at the moment it was just more specific to Ward 34. And then we made like a checklist or poster and attached it to drug trolleys, and it just basically said, have you flagged these antibiotics for review? How long have they been on these antibiotics? Do they need a review? Could they be switched to oral? Just really basic things. And then the third intervention, consultant microbiologist Dr. Ambalka very kindly delivered quite a few teaching sessions to the junior doctors on the ward. These showed a significant difference. Actually, after the implementation of these, there was a significant increase in the compliance in antimicrobial stewardship on the ward. Even though the presentations themselves were quite clinical, they weren't specifically targeting antimicrobial stewardship. But what I would say is that they maybe gave doctors confidence in stopping antibiotics. So we get a lot of diabetic foot ulcers on diabetic foot infections on Ward 34, and we should be we're not expecting that these wounds will heal by the end of the antibiotic course. And I think sometimes it can be hard for doctors to stop the antibiotics if the wound's not completely healed, whereas Dr. Ambalka did a presentation on this, and actually I think that maybe empowered the doctors a bit to say, you know, it's actually okay to stop the antibiotics before the wound's healed. And then of course EPMA implementation. Now we stole this was obviously had nothing to do with us really, but we mapped it all the same on our data collection, and we saw what change this had to the compliance with antimicrobial stewardship, and it did improve it in terms of what's on the drug card, because on the drug chart, because it you have to put in an indication, and that's one of the things that we audited, and you have to put in either a review or a stop date, or it at least advises that you do that. So that was much better, but the documentation in the notes was still not as good as we'd like. But sometimes that's to do with the clerking in admissions, and maybe is not really you know, the main issue there is not on Ward 34 with that, but that's maybe another quality improvement project. So this is our statistical process control chart. Now that first dot on the 6th of December, that is the mean for the 6 months before the quality improvement project started. So you can see it was at 59%. This, the solid line in the middle, that is the mean. And then the sort of dashed lines either side, those are the process limits. So in quality improvement, we know that there are fluctuations. We expect there to be fluctuations, and we don't respond to every fluctuation. And those lines are telling us within these sort of boundaries, this is sort of what we'd expect with no change at all. Like, so if you didn't make any equality, if you made no interventions, we'd sort of expect it to be in this ballpark. Now, what you can sort of see on here is that the nurse podcast, the nurse checklist, we were still within that sort of ballpark. We didn't see any significant changes with that. Now, interestingly, as you can see, the start of the teaching in sort of mid-January or mid-February, sorry, and then those weekly teaching sessions towards the end of those, after 3 sessions or 4 sessions, there was actually a increase in the mean compliance with antimicrobial stewardship, which is positive. And then after EPMA introduction, you can see again it increases, which is really good. We're still not, so they were currently at about 84% compliance. So it's not at the 90%, that arbitrary value that we assigned to the project at the beginning. But as you can see, I think that's really, really positive, the sort of changes that have been made on the ward. So some next steps. So we're going to be doing a lot of auditing as part of a sequin, which is related to urinary tract infections at the trust. So we're going to be doing a lot of auditing around that, and quality improvement as well, if we find that things aren't quite where we want them to be to get the sequin. A separate, as the antimicrobial prescribing audit doesn't actually take into account whether antibiotics are appropriately prescribed. So Dr. Ambelka wanted to do some work around that, and also moving this good work that we've done to other clinical areas as well. There are some contact details. I'm really sorry. I know I've not put all the quality improvement team there. Those are just some of the people that I've personally worked with. And I'd really, really recommend you get in contact with them if you're starting on a quality improvement project. They've just been indispensable. And there's my contact details and Desi's contact details. She's one of the other antimicrobial pharmacists. So thank you very much. Yeah, sorry, just some references. Thank you so much for having me speak. I'm sorry, I think I've gone over slightly. Does anyone have any questions at all?
Thanks, Anna. That was really, really informative and really gave a good sense of what you were trying to achieve. That's really important to the planning of the PDSA cycle. Make sure that sufficient time is on the planning and and also the scrutiny. You've got some actions there you're going to be taking, really some positive improvements in stewardship as you demonstrated, and great that you accessed the team and they were able to support you on this journey and presumably continue to do so.
Yeah.
So as Anna offered the opportunity for any questions, we did have I'm just reading it through, I'm not sure if it's a question or a comment. It's from Rachel, who said, "Hi Anna, apologies if you've discussed this during the session, but now we're doing the EPMA, will this alter antimicrobial prescribing, and will the medics be solely responsible for antimicrobial prescribing?"
So there are changes because the EPMA system mandates that you put an indication in. There are ways to get around that, and which like some doctors do utilise, and it doesn't mean that the indication that's put is correct. There are still a lot of work to do around the documentation in the notes and sending appropriate samples in the admissions units and on the wards. We find that is sometimes done quite poorly. But yes, absolutely, and the EPMA system did make a statistically significant difference in the antimicrobial stewardship compliance on the ward that we noticed.
Thank you. I'll just take a couple of minutes just to see if any more questions come through. But I just wanted to reflect to Barbara and to Craig. You know, really interesting set of slides that sort of introduce the importance. And I was particularly struck by the fact that clinical audit isn't something separate. It's part of the foundations. It's part of those building blocks for continuous improvement. And it's all our business. It should be something that all of us take a real good care to consider how we can improve the quality of care we give to patients, and that is continuous improvement, always thinking that way, and clinical audit is one of a really important tool in our toolbox here at the Trust in order to be able to do that. So I think you got that across really well, so thank you for that. I have a couple of questions. I think they're for Sally. So I'll turn to those now and hope that we get a couple more as we do so. So this is about lateral flow testing for staff, Sally. So will staff still be required to do the weekly testing?
At the moment, that's still the current guidance, and I did clarify that this morning. There potentially will be some changes to testing it in the coming weeks, but we're just waiting for clarification on that. But we've been told to continue with it at this time.
Well, I'm still getting my text reminders and requests to log whether I'm positive or negative. So I guess that was the case. So that will when and if that changes, or if and when that changes, we'll communicate that clearly. And then this is a sort of a question again about staff who may be immunocompromised and what other support might be in place. I guess, Adam, that might be something that you could answer.
Yeah, absolutely. I think it boils down to what support the person feels they need. Obviously, we've still got a really strong health and wellbeing offer with up the EAP. If people are experiencing a bit of nervousness, but anxiety about this move away from wearing masks, they can obviously contact the EAP and talk it through if that's what they're after. But I think really that conversation with the line manager reviewing the risk assessment is what's going to highlight what support may be needed, and then we can take it from there as to see what we can offer and what's reasonable.
Yeah, thanks, Adam. And I think you mentioned this earlier, but it's really key for me that we're supportive of all staff. So I think the majority of people that I've spoken to in the last couple of days are pleased that the compulsion to wear face masks has been has been removed, but clearly there are staff and visitors who will want to continue and feel safer to do so. So we need to be supportive, we need to be kind, and we really need to be understanding of those individuals and how we can support them. So thanks for that, Adam. Okay, can't see any other questions in the chat, so I'll close it there. I'll say thank you to Sally, Adam, Craig, Barbara and to Anna. Hope you've found today's staff brief really informative. I've learned loads, so that's great. Mind you, I always learn loads on these staff briefs, so so that's great. So thank you for your input today. Thanks for attending. Hope it's been informative, and we'll see you again next week. Goodbye.